think Mike and I are both wanting to be fly fishing here within a few hours, right? Well, I want to thank everybody for coming, and I really hate that I did not get to attend more of the conference and get to know y'all better. In all of the conferences I've been in, it seems like that people in telehealth are genuinely interested in the welfare of the patients and improving healthcare outcomes for large groups of people, and you're just generally a really good group of folks to hang out with. So well, I've titled my talk Bridging the Gap, and I'm going to have to define that gap here in a little bit. If I could just get a show of hands, who's in women's health? Okay, you're going to understand this talk really well, and the rest of you, if I get into terminology or situations that don't make any sense, wave your hand, throw a water bottle, preferably empty, something at me, get my attention, and I'll explain things a little bit deeper. But originally I wrote this talk for an OBGYN group, and I realized sitting here that I'm a little bit out of my neighborhood, so here goes. So originally, this was my original title, Telecolposcopy at Your Cervix from a Distance. And my team, Gordon Lowe, really is the heart and soul of the operation. He is an advanced practice nurse who's been with UAMS for about 8 years or so, a little longer than me, I think. And besides being just a wonderful person, he is an extremely good organizer, and he is tenacious at following up on details, which is unfortunately a talent I don't particularly have. Lisa Harmon, Tessa Ivy, and Becca Austin are APNs that are now or have been primarily located at UAMS. And Delia James is an APN that was primarily associated with the health department in the state of Arkansas, and now is partially employed by UAMS. But she really was a key person in the beginning of this. So try to divide this talk up into logical points. So the problem that we had is there's a problem of access to health care in general. And we found this particularly in women's health in a situation that I'll describe in a little bit more detail later. But part of that problem is poverty. And another problem is geography. So we're a poor state. I don't think that's a surprise to anyone who is visiting here. It's certainly not a surprise to those of us who live here. So you can see that 18% of individuals, 14% of families are impoverished, which is well over the national averages of 15.3 and 11.3. This is data from a few years ago. We've been a poor state for a long time. I don't know what it is about men and the Depression and their mule, but there's a picture of my grandfather with his mule that I should have included in this talk, but it looks very similar to this. But poverty has a little bit different look today. I mean, we have small towns that are decaying, people doing the best they can in those areas, and the broken-down wooden shacks have been replaced by old trailer houses in a lot of cases. And why is poverty important? Well, cervical cancer treatment's very, very expensive. These are some numbers that are from Arkansas, cases of cervical cancer that were treated, and the cost was $2,900 per case, but a total of millions and millions that were spent. So geography, the other part of the problem is Arkansas is a rural state, okay, and that's shouldn't be too much of a surprise to most folks. However, I mean, I think, are most folks from states that touch Arkansas? Okay, so you've all got areas of, or large rural areas as well. Alpena is a population of 319. That's a moderate-sized town in a lot of Arkansas. And there's some beautiful things about being in a rural state, and but sometimes I feel like this guy standing on Hawks Beach Crag here kind of by yourself when you're out there working in a rural area. And I say this because I worked in Hot Springs, which is only an hour away, and you could argue very convincingly that it's not a rural area. I had a lot of patients that came in from an hour and a half west of Hot Springs. So I dealt with some of those issues about patients in rural health settings. I mean, patients that come into Little Rock was, something they rarely or never did. I mean, they didn't want to drive in Little Rock. They were terrified of the traffic and things like that, things that some people like us that live in cities, I imagine do most people live in relatively urban, suburban areas? And so things that we wouldn't think about, there's folks that never have to think about that. They just don't go to cities, don't want to. So in rural areas, we found that cervical cancer screening rates are lower, and that's been well established in other literature. And a lot of the information that I'm going to present today is compiled in a paper that's going to come out about our program. It's in press right now. It should be out in about a couple of months. I think it's coming out in about 2 months. So looking at part of the problem here, lower cervical cancer screening rates. So cervical cancer screening is a pap smear. I think probably most people are familiar with that terminology. Well, we have reasonably good coverage for pap smear services in Arkansas. Well, I'm getting a little ahead of myself here. Talking about rural areas again, women generally are less educated, more likely to be impoverished, and have worse outcomes when they are unfortunate enough to get cancer. So this rural nature of the state compounds the problem. Being a rural and impoverished area, we end up having a lot of medically underserved areas. And actually, there's 73 of the 75 counties in Arkansas as of a couple of years ago, were classified as medically underserved areas. I was a little bit surprised to realize that the two areas that weren't were Grant County and Boone County. And I don't know if y'all are from Arkansas are familiar with those two counties. They're kind of rural in themselves. The red counties here, including Pulaski, where you sit right now, is at least partially underserved. And I've heard some newer numbers that suggest that every county in the state of Arkansas, there's at least some of the area of it that's classified as a medically underserved area. So it's a target-rich environment. There's a whole lot of good that can be done because there's a whole lot of people that are in need. So now, that's our general problem about healthcare in Arkansas. Our specific problem that we're going to talk about today has to do with cervical cancer screening, and more importantly, the follow-up to abnormal cervical cancer screening. So typically a patient gets cervical cancer screening, a pap smear, and if it's abnormal, the follow-up test is called colposcopy. And what that basically is microscopy of the cervix and directed biopsies. Well, that's pretty expensive. I think somewhere around $700 is the retail rate on it. While the entire state virtually has some kind of coverage for pap smears, there was a huge gap between uninsured women and Medicaid, full Medicaid eligible women to get this colposcopy. Paradoxically, there was pretty good coverage for the women whose biopsy put them at high risk of cancer. If they had a high-grade biopsy of the cervix after this colposcopy, then they could get qualified for another program that would cover their treatment, which is also much more expensive than the colposcopy. But they had to take about a $750 gamble to get to that point, and about 3 out of 4 of those women who get colposcopy don't have a high-grade lesion. So 3 out of 4 of those women that forked over the money were going to get to just eat that bill. So a low level of patients could go through with this. The way we had dealt with this up to 1996 was the health department actually was able to provide colposcopy services. We had doctors that traveled out health department employees and such that went out to health units all around the state. I remember doing this when I was a resident. We covered one of the clinics, but we went out all over and covered these colposcopies, and the patients got pretty good care. But in 1996, the money got so tight that they could not continue doing that. Strangely enough, sometime right before or right after that, funding to cover pap smears and birth control was actually expanded. Some of you from Arkansas might be familiar with the fact that our qualification standards for Medicaid, if you're not pregnant or disabled, are really, really, really strict. I mean, we're one of the, I think, 3 stingiest states in the union as far as covering people for Medicaid. But if you're pregnant, I think it's up to 100, is it 200 or 138% of poverty? It's a much more generous number, such that most women can qualify for coverage if they're pregnant. Well, what they did back 10, 15 years ago is they expanded cervical cancer screening and contraceptive coverage to those patients. It was like a family planning waiver. Unfortunately, that wasn't really full Medicaid. It just covered those services only, and it specifically did not cover colposcopy. So when I was in private practice, this was very, very frustrating because the patient could come in and they could have their pap smear, but then we couldn't do their colposcopy because they couldn't afford to do it. And it's not just a matter of, those stingy, money-grubbing private practice doctors, which I used to be one, don't want to do it. It's, you're actually paying your help to do it. You're paying for supplies. You're taking on risk, medical legal risk when you do that. So, I mean, I really can't blame private doctors for not, providing these services for free because it's not really a smart business thing to do, and it exposes them to risk unnecessarily. So that was the conundrum there. Is patients can get the first level of screening, they can't get the follow-up. If they're lucky, or you should say unlucky enough to have high grade, then coverage picks them up. So we had this gap here, or sometimes we described it as a donut hole in the coverage. So health department, there was 2,000 abnormal pap smears in a 12-month period. Less than 30% of these patients were getting colposcopy. So some of them were scared enough to fork out the money and do it, but less than 30%. So there's all these patients that are getting abnormal pap smears, and what do you do about it? It's almost like you should just quit screening that population if you can't continue taking care of them. But, we did have some coverage for the dysplasia if they did have that in a high grade. So before I came to, I don't want to take credit for the program because the program started before I actually returned to UAMS. As Michael was talking about, I stayed connected with UAMS. When I went out in private practice, it felt pretty lonely. I spent a fair amount of time on the phone talking to my professors, running cases by them. And it wasn't but about 2 or 3 years after I started private practice that the Angels Network started being put together. And one of the great things that we did was, or that the program did, was it extended some learning opportunities and some collaboration opportunities as far as case discussion to a lot of doctors around the state. And I, for years, went to a Thursday morning conference, and several of my friends from around the state, and we all logged on, and it was like we were sitting back at UAMS during a high-risk OB program. So that's, was one of the things that really kept me interested in doing it. But about when I came here in 2007, this program had really just been started for about 6 months or so. Martha Brewer, I don't know if any of y'all know Dr. Martha Brewer. She's now in Louisiana, but she was here and was the chief of my division, was very active in this program when the pilot was started. So we thought, let's use some telehealth to improve access, and let's try to find some more readily available providers, nurse practitioners, that we can send out closer to the patient to provide this care. One of the, and had been thinking about these kind of things, and I continue to run these kind of things through my head. we've got a huge challenge with healthcare in America, where we're spending more than twice really, what the average country spends as a percentage of their gross domestic product on medicine. We're really, really overspending on medicine. And as pressures mount, as they are today, we have got to figure out how to be more efficient. And one of the things, one of the mantras I hear and keep repeating is we've got to leverage technology to make ourselves more efficient. And when I heard about this, I thought, I can multiply myself by about 4 or 6 or 8 and provide care to a lot more people. Of course, I have to kind of divide my nurse practitioner crew into that because they're not free. But I can multiply that and extend the reach. Not only multiply it, but extend the reach as well to make ourselves more efficient and improve access. So a pilot project was started in Hempstead County, and that's where Hope is, the birthplace of President Clinton. That's where Delia James that I mentioned at the beginning. She's a public health nurse there, has been there forever, knows everybody. She's a great asset to that community, and she was the ideal person to start this kind of thing. She instantly establishes rapport with patients, and they amazingly do almost everything she tells them to do. So she was very good at getting people to follow up and show up. So we used this, we gathered some data and used this to support a grant application, and we applied to HRSA, and I think this slide got out of order, so we're going to run into it here in a minute. But what we wanted to do was expand it from 1 pilot site to 3 sites, and basically triple the number of patients that we could see. So part of that was we were going to take a lower level of providers who were unfamiliar, some of them totally unfamiliar with doing colposcopy, and we were going to rapidly train them, and then with our interactive video link, we're going to provide them support and guidance so that they'd be comfortable enough to provide good care to the patient on the distant end. It borne out with the one super nurse we had, Delia, so we thought we could expand this to nurses that were less familiar. So we did some training. There were 3 2-hour sessions of didactics, and then there was an 8-hour session or 2 4-hour sessions of observation, and then another 8 hours worth of supervised colposcopy on site here in Little Rock. And then after that, they went out into the field with an experienced colposcopist, Gordon Lowe, the real kingpin of the program that I keep mentioning. He's very experienced. He would go out with them and make sure they were comfortable in several 4-hour sessions, 2 to 4 typically, until the nurse practitioners were comfortable performing the exams. All the while we have the video backup in Little Rock. So the grant we talked about, we tried to figure out where our referrals were coming from, and these darkest blue areas, let me see, and you can see, over here, and we had a couple right here, Sebastian and Polk County, and then down here in southwest Arkansas. So we found health departments that we could cooperate with. One was at Cross County, which is in Wynne. I'm sorry, I didn't mean to do that. So over here at Wynne, this one red star here, and then Johnson County is Clarksville, which if you've ever driven west across Arkansas, you've been real close, you've been right through Clarksville. And then down here in Hempstead, this is where Hope is. So those were the logical places to target. So that's where we started, and we were very successful. And this is the placeholder for a video that would make the presentation run too long. So this would show you what would happen. This slide's a little bit busy, but we tried to depict what was going on both ends. So this picture here represents the distant site where the patient is. And this is one of our nurse practitioners, Tessa Ivy here, and here is an actress patient. And we have a telemedicine unit in each of these areas that has a digital colposcope attached to it. But they also have a camera so you can do face-to-face talking. We don't do a lot of that, but occasionally we do. The patients do hear us talking, and a lot of times we will do some counseling and do some reassurance. But we end up not having to interact from the hub site with the patients because our nurse practitioners, as in generally they do, they bond really well with patients. Get my arrow back. So I sit in Little Rock at a desk with a unit, and there's a small screen there, but I'm actually usually looking at this big 60-inch screen, which is about 4 feet in front of me. And typically we have the one site that we're paying close attention to, but we have the ability to have 3 more sites over here that we can watch what they're doing and pull them over to the active screen as needed. And being able to do that really helped us because the way we had been doing it before was with 2 units and flipping back and forth between sites. Being able to see what they were doing when they were ready has made us a whole lot more efficient. They don't have to wait for us. Thank you. So I'm going to have to pick the pace here just a little bit. So this is actually Delia, and this is what she sees on the distant end looking at a video screen with a patient up in the stirrups. So what were the results? Well, in a period from April of one year to February of the next, we saw 813 patients. Almost all those we did biopsies on, and a shocking number of them, 28% of them were high grade. Really, the numbers would predict more like 20% if you look nationwide at what's the odds of a pap smear having a high-grade biopsy. So that led us to think, my goodness, we were right. These underserved patients are more likely to have a high-grade lesion. And my theory on that is that they've just been delaying care and couldn't get in. And indeed, that's what they told us. A shocking number of them, 60% of them, said that they would have delayed, if they couldn't have gotten this service for basically free, that they would have delayed care for a year or more. So how good was our model? Well, we have we have a pretty good positive predictive value for high grade compared to national, and overall we had very good sensitivity as well. Our sensitivity for high grade was a little bit lower than what we expected it would be, but our sensitivity for any lesion was actually a little bit higher than what we expected. This is another slide from the paper that's coming up that just talks a little bit more about the patients that would have deferred care, some demographics on that group. And this is the high-grade biopsies, where did they come from? So 20% of them came from ascus paps, 28% from 20% of those ascus ended up being high grade, which was higher than we expected. 28% of the L-cells. I've got a very sensitive finger today, sorry. And then a lot of the H-cells, a lot of the high grade biopsies came from H-cell paps. So we've been through that number there. We were pretty accurate. We did find a cancer. We found 5 carcinoma in situ, and of the group that needs further attention, that has a higher chance of turning into cancer, there were over 300 in that group. One measure of success was, the patient satisfied. Well, 90% gave us a highly or strongly agree or agree with, I'm satisfied with these services. And all of them, of note, all of them were offered a chance to come to Little Rock to have the services performed, but almost all of them chose to stay closer to home. So the cost effectiveness, if you use this model, we have 1 physician and 4 nurse practitioners, each with an assistant. You get the cost down to about $40 per exam, whereas the traditional model where you have a doctor and an assistant, it would be $52 per exam. So that's a significant savings when you talk about the thousands of women that we treat. Another way of looking at cost effectiveness, I won't belabor this, but cost for quality years of life saved we're well under the $50,000 threshold that is considered cost-effective. Okay? Well, Pap smears in general are as a strategy. What's the risk of these things progressing to cancer? Well, the CIN2 has about up to a 20% risk, CIN3 up to 50%, and virtually all of the CIS biopsies will progress to cancer. So from an 18-month period that we describe in our paper, it's estimated that we prevented somewhere between 30 and 120 cases of cancer by getting treatment to these underserved patients. So in the future, we may not get our flying cars, but maybe we can improve access and have some cool side effects from this. So clinical applications, obviously rural underserved areas anywhere in the United States. The borders don't mean anything to telemedicine as long as you can get connectivity, so this is something that can be taken anywhere in the planet. We've had serious contacts with a missionary in Africa that has an interest in cervical dysplasia, but we've yet been able to make a connection. And then there's some people that have contacts in Haiti that would be a good area, an underserved area. Okay, telestration is something that really hadn't been done. We can write on the screen to help the person at the distant end understand what they're seeing and help guide them and comfort them. And then we can do image capture for quality control. We saw almost 1,000 patients in the last 6 months. And we made a successful proposal for a second round of funding and to expand the program. I think I'm going to stop there because I've run over just a little bit. Are we going to save questions to the end?
Yeah, to the end.
All right.
Thanks, Chuck.